So today's webinar will cover health plan design, including cost sharing charges and marketplace plans, eligibility for cost sharing reductions, and how plan design affects consumers' costs. It will also include information on the expansion of Skimpy plans. And to guide us through today's presentation, please welcome Sarah Lueck, a Senior Policy Analyst here at the Center on Budget and Policy Priorities. Take it away, Sarah.
Hi, everybody. Thanks for being here today. I know a lot of you know a lot about plan design, but what we like to do before we go beyond the basics with this presentation is to go back to the basics a little bit, just to review before open enrollment begins. So there's two major categories of costs that I'm going to be talking about that you see in plans. One is premiums, the monthly cost that a person pays for a health plan. And the second is the one I'm mainly going to be talking about today, which is cost sharing charges, the charges that a person pays as they use benefits that are covered by their health plan. So some of the key building blocks of a marketplace plan, there are the covered benefits. And in the case of marketplace plans, that means the essential benefits, including preventive services, and potentially additional benefits if the health insurer chooses to offer them. There is also a provider network component of a marketplace plan. This means that insurers contract with a healthcare provider and makes them part of the network. So that would include physicians, hospitals, and other medical professionals that provide services to plan enrollees. A plan could have a broad network with a greater number of providers or a narrower network. A lot of times the networks of the marketplace plans are narrower. And the plan may or may not provide any coverage outside of its network, which is something we'll talk about as we go through the presentation. So I mentioned the essential health benefits. These are 10 general categories of benefits that all marketplace plans have to include. There's more specific services within these categories, but these are the general things that people can expect when they get a marketplace plan. It's everything from ambulatory patient services, so that's like going to a physician, to emergency services, maternity care and hospitalization, as well as labs, prescription drugs, and rehabilitative and habilitative services. So those are the broad categories that all the plans include. The types of cost sharing charges that people pay when they're enrolled in a marketplace plan include these three terms. The first is the deductible. That's the amount the enrollee has to pay before the plan begins to pay for most of the benefits, set on a yearly basis. And it's usually a pretty large number for people that don't get a cost sharing reduction. The co-payments are amounts that, a dollar amount that a person pays when they go to the doctor or get a prescription, a flat dollar amount. And many of them, in some cases, for some of the common services, are things that that person might pay before they've reached their full deductible amount. So that's good news for people. Co-insurance is the percentage of the cost of an item or service that an enrollee has to pay. So that would be, for example, if you had to pay 10% or 20% of a doctor's visit or of a prescription drug, that would be an example of co-insurance. Another important element, really a protection for folks when they have very high medical costs during the course of the year, is the maximum out-of-pocket limit, OOP for short. So this is an amount that's part of all the marketplace plans, and it puts a cap on what an enrollee has to pay in cost sharing charges each year. This is set on a yearly basis, and it has to apply to in-network services, but not to out-of-network care. And also important to remember, because sometimes people get confused, the out-of-pocket limit is not the amount that an enrollee must spend this year. In fact, most people won't get close to this limit, but it is an important protection, especially for folks that end up in the hospital or having treatment for an expensive illness. So in 2020, the maximum out-of-pocket limit for an individual in an individual plan is just over $8,000, $8,150. And for a family, the amount is $16,300. Although with a family plan, no individual in that family can be required to pay more than that $8,150 that you see for an individual. That's intended to really help protect people against those catastrophically expensive situations. You can also see in the table at the bottom of this page that people at lower income levels get access through the cost sharing reduction plans to reduced out-of-pocket limits, both for individuals and for families. So that, is in recognition that at lower income levels, people have even less ability to pay for expensive medical bills. And so, for example, somebody between 151 and 200% of the federal poverty level, that individual wouldn't have to pay more than $2,700 in out-of-pocket costs for that year under their plan, compared to $8,150 for somebody who has income over, higher income level. A couple additional items to know about cost sharing charges. In a plan, some services may be exempt from the deductible. This is known sometimes as first dollar coverage. And I mentioned this before, sometimes co-payments are not part of the deductible. So even if a person hasn't paid, $2,000 or $6,000 out of pocket yet for their deductible, they can get access to certain benefits without having met that yet, and maybe just pay a co-payment or a portion of the costs. So an example would be maybe a plan covers 2 physician visits and charges the person $25 per visit, even though they haven't gotten a bunch of other care that year and haven't met their deductible. Some plans may provide, for example, generic drug coverage and let people fill prescriptions for generic drugs just with a copayment at the pharmacy without also having met that deductible amount. And that can be a good way for people to get access to some commonly used services without having to spend large amounts of money. It may be something you may also see in plans is that there may be some services that have a separate deductible. And one example where that has happened is prescription drugs. And oftentimes it's a lower deductible perhaps than the overall deductible under the plan. And that's designed to kind of give people access to a prescription drug benefit at a lower spending level. So cost sharing and metal tiers, I think a lot of us have heard these terms, these metal levels to describe the plans in the marketplace: bronze, silver, gold. Those are really based on actuarial values, and we're going to talk a little bit more about what that means in a moment. But in general, just as you use healthcare.gov or other marketplace sites, you can just keep in mind that if the metal level is higher, if it's gold versus a bronze, for example, the gold plan is going to provide greater coverage, and the premiums for the consumer are going to also be higher compared to a bronze plan, where there will be probably higher out-of-pocket costs for the consumer and also lower premiums. So what is actuarial value? It's just a way of estimating how generous a plan is. It's a technical term in the insurance world. It is a math problem, essentially. To calculate actuarial value of a plan, what an insurer does, it assumes the entire typical population enrolls, a general population. So some people with very high spending and some people with no spending, for example. And then there's an estimate of how, what the percentage of cost is that the plan will pay for the covered services used by that population. If, for example, the plan pays 70% of the cost of covered benefits or around that amount, that would be a silver plan. And there is a calculator that insurers use that's federally established to try to do this calculation, so it's standard across plans. Important to know, if you're thinking about actuarial value when you're looking at these plans, it does not mean that percentage, for example, that 70% is what the plan would pay for a particular individual in the plan. So it's not that if you enroll in a silver plan, that plan's going to pay 70% of your costs, because there's a lot of other variables at work here. The enrollees' costs, what they actually use, makes a big difference. So that will determine how much coverage the plan provides. And it also, the actuarial value does not determine what benefits or prescription drugs are covered by the plan, and it doesn't impact the provider network. So there's differences in the plan that affect what the enrollee pays that are not part of the actuarial value calculation. In very simple terms, the actuarial value guides what the cost sharing charges are when the insurers are designing these plans. So as you can see on this slide, the bronze plans have usually higher deductibles than the more precious metal levels. So the gold, for example, on this slide has no deductible at all. and the bronze plans have either a $7,000 deductible or $5,500 deductible. That means obviously their premiums are going to be lower, their total premium is going to be lower, but their out-of-pocket cost for the enrollee is going to be higher. It can be confusing sometimes to understand how cost sharing works, but we wanted to try to put forward a little bit of a simplified explanation by using this example. So this is a very simplified plan with a, you can see there the deductible of $5,500 and different co-payments and co-insurance for various services. We're going to imagine, I think her name is Carla, that Carla has about $13,000 of health costs for the upcoming year. And you can see the calendar there. This is meant to sort of show you how an enrollee's costs accumulate over the course of the time they're enrolled in the plan. So initially, Carla has a health event. And in this case, with the high spending that we're seeing here, she's probably being hospitalized. And initially, she has to meet her deductible. So she pays $5,500 herself. That's all the costs in this case that she owes, plus she's paying $75 in copays. Once she reaches her deductible, she is, done with that large amount because she was in the hospital and that cost a lot of money. She's then going to be paying co-insurance and co-payments for some of the follow-up care she's getting. Maybe she's getting some primary or specialist visits after she gets out of the hospital, and then she needs some care as the summer comes on and fall comes on. Maybe she's getting physical therapy or other kinds of follow-up care. You can see she's paying co-insurance and she's paying copays during that period of time. And eventually she reaches her out-of-pocket limit for the year, $73.50 in this case. It happens around September in this example. And then once she hits that limit, Carla is not paying any more out-of-pocket for in-network services that are covered by her plan. Instead, the insurer, the plan, is covering 100% of the remaining costs until we get to December and the year ends and the plan starts over again. Another thing to be aware of is, and it's a simple fact, but it's one worth just knowing, is that usually with an individual plan, a plan that's going to cover one person, the deductibles and the out-of-pocket limits are like this. The amounts you see here, for example, in this case, $5,000 for the woman on the left who's going to sign up on her own. For a family that's going to sign up for that same plan, that amount is going to be doubled usually. So that's just important to remember. That doesn't mean that that family is going to have to spend $10,000 out of pocket necessarily. Each of those people is protected by an out-of-pocket limit that's, applying to the individual. But it does mean that the plan design is going to have double deductibles and double out-of-pocket limits when you're looking at family plans. Embedded and aggregate family cost sharing. This is just another plan difference that can exist that it's worth being aware of. With embedded family cost sharing, that is, in that case, in addition to a family deductible, there might be smaller individual deductibles that are sort of nested within it or embedded. That can happen also with the out-of-pocket limit. So in addition to the overall kind of family out-of-pocket limit, there might be smaller individual out-of-pocket limits that apply to each individual. And in fact, with marketplace plans, there is that individual maximum out-of-pocket limit that exists for every individual, as you can see at the bottom of the screen with the exclamation point. So no individual can be charged more than that annual limit of $81.50 in the case of people who don't get cost sharing reductions, or lesser amounts, as we talked about earlier, for people who do get cost sharing reductions. With aggregate family cost sharing, all family members' expenses, if it's an aggregate deductible, all family members' expenses are pooled toward that one combined deductible. And an aggregate out-of-pocket limit, all family members' expenses are pooled toward a combined out-of-pocket limit. So this is really a question that comes up if you're helping families enroll in a plan, and typically it can be found out by looking at the plan's marketing materials, but it is worth knowing if you're helping folks perhaps to identify how the cost sharing works in the plans that are available in your area. In-network and out-of-network cost sharing is also a difference that plans can have. Here you can see that Plan A has differential cost sharing for in and out of network, right? It has higher cost sharing if the person uses a provider that is a healthcare provider that is not in the plan's network. With Plan B, you can see that there actually isn't any out-of-network coverage available. So if a person is enrolled in that plan, rather than just paying more under the plan, they're actually not going to get the benefit of their coverage or network rates. So there isn't really out-of-network care, and it would be really important for someone in a plan like that, and really any plan with big cost-sharing differentials, to really try to use in-network providers and try to pick plans that have their providers or providers they're going to be able to get to. With Plan C, this is a more complex design, tiered network cost sharing, meant to sort of incentivize people to use the lower cost tier. So somebody would save the most money if they're using providers that are in tier 1. They would pay more if they went to providers in tier 2, and they would pay even more than that if they went to providers in tier 3. So just another design feature that insurers might have in their plans that you can be aware of. It can be a huge difference for people in the marketplace plans, whether they're using in-network or out-of-network coverage. In this example, we're saying we're using Plan A, so there is out-of-network coverage in this plan, but it's much higher for somebody using an out-of-network provider than an in-network provider. In this case, you can see the person goes to a network physician and the doctor's bill is $200. What the plan is going to pay is what's known as the allowed amount. And with a network provider, an in-network provider, that doctor has agreed to accept that allowed amount as the payment, full payment for their services, even if maybe they would charge more to another patient. In this case, the plan pays $75 and the patient owes their $25 copay. And what the patient is paying in that situation, because it's in-network, does count toward the in-network out-of-pocket limit under their plan. Now, in contrast with an out-of-network physician, we're saying here, let's imagine the doctor's bill is the same, it's $200, and the plan amount is $100. In this case, the plan isn't paying as much. It's paying a lesser amount because it's an out-of-network care, and the patient is going to be paying the difference between the doctor's bill and what the plan is going to be paying. So the patient's paying much higher amount in this case, $150. And in fact, that amount doesn't count toward the in-network out-of-pocket limit under their plan. So that's another sort of downside of using the out-of-network care. Cost sharing reductions. This is a really important element of plans for people in marketplace coverage. What are cost sharing reductions? This is a federal benefit that reduces what people pay out of pocket for the covered services in their plan. It is available to people with incomes up to 250% of the federal poverty line. And in order to receive this help, you have to enroll in a silver plan through the marketplace. The other metal levels don't provide this assistance in general. And so 3 levels of cost sharing reduction plans, as you can see here, based on income. The first is above 250. That's the first column is sort of the standard 70% actuarial value and what the required out-of-pocket limits are. You can see that with the CSR plans, there's higher actuarial values being provided to people as their incomes are lower, that actuarial values are higher. And that translates, as we discussed before, into lower deductible amounts as people's incomes are lower, and also lower out-of-pocket limits as their incomes are lower. This is just an example. It's, different insurers will design different plans consistent with the actuarial value standard that meet the requirements for the CSR plan. So this is just an example of how one plan, in this case, a Pennsylvania plan from 2019, is modified from the standard version in the first column without a CSR to these other versions for people at different income levels. And you can see, for example, the deductible, if you follow it across toward the right of the table, it goes down quite significantly so that people who are under 150% of the poverty line are able to pay a $300 deductible rather than a $4,650 deductible. You can also see at the lower part of the table that the copayments for a primary care visit and for specialist visits are going to go down as people are able to access the cost sharing reduction plans, and they're going to pay lower amounts in order to get prescription drugs. This is another example, a plan, also a 2019 plan from Pennsylvania, just a different example of how an insurer might treat it differently. And in this case, the deductibles and the out-of-pocket limits are changing in order to give more assistance and more coverage to the people with lower incomes. But the 10% cost sharing after the deductible that you see on the standard no CSR plan is, carried through to the other levels. So really, it's all about, in this case, the deductible. And this is just to show that different insurers will, different plans will be designed differently depending upon what the insurers decided to do. So it's still important with the cost sharing reduction plans for people to understand that there's different cost sharing that they're going to be paying if they're enrolled in one plan versus another. The amounts are lower, but the differences can be meaningful to people. So it's an important thing to tune into. For example, here you see two plans. They're both AVs of 94%. They're both cost sharing reduction plans for the same income group. They have different deductible amounts, they have different out-of-pocket limit amounts, and they have different kind of plan designs and cost sharing designs. So it's obviously important for folks, even when they're getting cost sharing reductions, to pay attention to differences between plans. You may have heard that in 2017, the federal government ended reimbursements to insurance companies for cost sharing reduction plans, but it's important to know that even though the federal government did that, people who are eligible for cost sharing reductions can still get that assistance, and they can enroll in a plan with reduced cost sharing charges so that they're unaffected by this change. And the plan designs for the CSR plans are also not affected. So the insurers are doing basically the same things they've always done related to the cost sharing designs that they've made. Basically what they did is that to cover the costs resulting from the termination of CSR payments, insurers increased their premiums. And in most states, they did that by loading the costs onto the premiums for silver marketplace plans. If you, particularly if you live in an area where you're going to be seeing a lot of clients who are American Indians or Alaska Natives, it's worth knowing that there are special cost sharing assistance. There's special cost sharing assistance available to people who are members of federally recognized tribes and Alaska Native Claim Settlement Act Corporation shareholders. I'm not going to go through everything on the slide, but definitely an important thing to be aware of. They have more access to help with their deductibles, co-payments, and other cost sharing, depending upon their incomes. As Kyle noted, there is going to be the section of the presentation, unfortunately, on Skimpy plans because we're anticipating that they're becoming more common out in the real world and that people need to be aware, both consumers and the people helping them, that these are out there. People might be seeing them on the internet. They might be hearing from folks that are selling them. They might see TV commercials or web ads. So they need to know, and you should know how to spot the difference or help people understand kind of what's missing with some of these coverage options. When I say skimpy plans, I'm talking basically about plans that are exempt from some or all of the insurance market standards and consumer protections that otherwise exist for health insurance that individuals buy. So some of these plans can charge people higher premiums based on their age, their gender, their health status. Some may deny coverage based on somebody's pre-existing condition. They may not cover claims related to someone's pre-existing condition, and they may be leaving coverage out for certain essential health benefits that marketplace plans do cover. Some of the types of plans that we expect are going to increase, and maybe already have, are short-term limited duration plans, association health plans, healthcare sharing ministries, which has certainly grown. And then some other types that maybe are less talked about in the news, but are still worth being aware of, are indemnity plans and combination or bundled products. Those are sort of not any of the other first three, but they have very limited benefits sometimes. And they don't have to meet all the rules that insurance otherwise has to. So this is a chart. I'm not going to go through all of it, but it's a good reference if you're trying to understand what protections apply to some of these plans and don't apply to others. You can see the green check marks are there for the ACA plans. So that's really those are the ones that are going to be providing people with all these protections that have become so important to so many folks. So just important to focus on trying to get people to be aware of the ACA plans and help them understand all the benefits that are coming with it and the protections, both for their access to medical care, but also their protections against financial harm. So short-term plans, this is one we focus on a little bit extra because it seems the most like health insurance sometimes to people. Federal rules were changed beginning in 2018. These plans that used to be only allowed for up to 3 months or less than 3 months under federal rules, the rules were changed and they're able to last for up to 1 year and to be renewed. States still have authority to set limits and standards for these plans, and many have, as we'll talk about in a moment. But these are the ones that people might be attracted to because the premiums seem lower, and they might look kind of similar to a comprehensive health plan. They'll have a premium, they'll have a deductible, they'll have a provider network, but they're going to leave out key protections and coverage, because the reason that they're cheaper is because they actually are offering less coverage and they're covering healthier groups of people. They don't have to cover people with pre-existing conditions. So another important thing is that if somebody enrolled in one of these plans, it doesn't count as minimum essential coverage. So when the plan ends, they don't get special enrollment periods in order to get a marketplace plan. They would have to wait, just like somebody who doesn't have any coverage at all, in order to get in during open enrollment, in order to experience a circumstance that triggers a special enrollment period. Short-term plans are exempt from most standards that marketplace plans have to meet. So often the biggest thing is that people could be denied outright because they have a pre-existing condition. But if they do get coverage, their pre-existing conditions won't be covered. And there will be broad exemptions in the plan for anything that the person might need that could be related to some pre-existing condition that they had in the past. The short-term plans are also not required to cover the essential health benefits that we talked about at the beginning of the presentation. Frequently, they don't cover prescription drugs. They don't cover maternity care. They don't cover mental health benefits or substance use disorder treatment. So I actually have never seen a short-term plan that covers maternity care. So that's a big difference. They don't have the same limits on what people have to pay in cost sharing. And they can also put overall limits on how much they're going to pay out in a year, in the term of the policy, or over a person's lifetime. So they can just limit the amount of money they're going to spend. And that's not allowed in marketplace plans. Here's just an example from a website, the broker website that sells these kinds of plans. And as you can see, just to illustrate the point, they do look a little bit like what you'd see if you went to healthcare.gov. They have a premium. There's different providers with names that sound like insurance, that are insurance companies, and they have out-of-pocket maximums and deductibles, but there's a lot of differences, as I said, between these plans and the ones that you'd actually find in the marketplace. Also important, even though their premiums are low, maybe compared to an unsubsidized marketplace plan, for lots of folks that are eligible for subsidies, not only are these sort of a bad deal just because they're not as comprehensive in terms of coverage, they also, people may be attracted to some of these sites or buy some of the really intense marketing that's happening, and they may not realize that they're eligible in the marketplace for subsidies like the premium credits and the cost sharing reductions that provide them much more value and protection, and may even give them a better monthly premium. So I've included in this presentation just some examples of how the benefits differ, how the cost sharing differs, so that hopefully you could spot these in the wild if a consumer looks like this, coming to you with something that looks like this, or they're enrolled in this, or they're interested in this. This is the kind of thing you might see. There are maximums, coverage period maximums for how much they'll spend over the period of time. There may be dollar limits on the particular services that are provided. So dollar limits on the hospital coverage, on surgery, that really limit what the plan's going to pay, even if the benefit is included in the plan. So that can leave the individual that's enrolled paying a lot out of pocket if they ended up going to the hospital or needing a lot of the care that you see here. I mentioned the broad pre-existing condition exclusions. That's really important. I put some examples here just so you could see just how broad they are. Some of the plan documents will say, here's what's not covered. The exclusions and the things that are not covered will be stated somewhere in the fine print, but it might not be obvious to a consumer that's just getting a call on the phone and being told this is a great plan. And they may have those limits on the amount of money they'll pay for benefits. Long sometimes very long exclusion lists of what's not covered that are worth paying attention to. And there might be specific kinds of exclusions like this for hazardous activities or sports that are not really what you see in a ACA marketplace plan, but are just ways, in this case, of the insurer kind of limiting what it'll pay for. And I mentioned that states have the authority to set limits for these plans, even ban them altogether, or require them to meet all the same rules that regular health insurance plans in the marketplace have to meet. And the map just shows that a number of states have taken action since the rules changed, and in some cases before the rules changed, to either ban these plans or the red states that you see up there, or restricting them to less than 3 months. So that's what the federal rules were before they changed. And that really, I guess, recognizes that the short-term plan is a short-term plan, not a long-term plan, and that the person will view it that way rather than thinking about it as a regular health insurance plan that's providing them a lot of protection. So about a dozen states have strengthened their protection since the rules were announced. But unfortunately, most states do allow short-term plans to last 11 months or longer. So if you're in one of those states, this is definitely something to watch out for and make sure that consumers are aware of. Another development that we think is worth knowing about, and is tangentially related to the skimpier plans, is that in FFM states, the use of direct enrollment and enhanced direct enrollment has increased, and probably is going to be even more this enrollment period than it has been in the past. With direct enrollment and enhanced direct enrollment, insurers and brokers, which includes web brokers, can use their own websites rather than the FFM site to help people apply for and enroll in marketplace plans and receive their subsidies through the marketplace. With direct enrollment, the consumer is sent during the process to the FFM for an eligibility determination and then sent back to the direct enrollment site, so the insurer site or the web broker site, to make a plan selection. With enhanced direct enrollment, the insurer or the broker that's set up to do it can keep the consumer at that non-FFM site for the entire process. And in our research on some of the DE and EDE websites, we did find that they sell short-term plans and other kinds of subpar health plans. While federal rules do bar those types of plans from being displayed alongside QHPs when someone is shopping actually in that sort of DE, EDE experience, some of those sites that are approved to do DE and EDE do heavily promote these other kinds of plans. So it's just important to keep an eye out for that as well. What can you do about these issues we've just been talking about? I think number one is promote during open enrollment, promote open enrollment for the plans that do meet ACA standards so people don't miss the deadline and feel like they have to buy something that's substandard. I think that another really important thing would be to help consumers understand that there's risks with short-term plans and some of these other types of skimpy coverage, and that it's not all about the low premium, even though that's the first, probably most important thing for most people. It isn't the full picture. It's also going to be important after open enrollment is over to promote special enrollment periods. So when somebody has a coverage gap, they realize that there's ways to get a marketplace plan rather than having to get a short-term plan. And the marketplace plan actually will provide them with better protection for that time when they're between jobs or when they leave Medicaid and they've become eligible for marketplace coverage, for example. It's important also to continue to use the marketplace website as is required for navigators, for example, and to help consumers avoid the risks of direct enrollment and the confusion that can happen. That also helps make sure that they're going to see all plans, because the insurer websites that do DE and EDE, those are not required to show them all plans. So they'll make sure that they'll get the most complete view of the plans that are available to them if they use the marketplace website. A couple of other things that would be great to do if you have the bandwidth are to track and report what's happening on the ground, to be aware and look for misleading or fraudulent marketing tactics, to monitor the accuracy of the information that's being provided to consumers, to track the experiences of people who enroll in some of these skimpier versions of plans, and to let your state insurance regulators know if you're seeing instances of potential fraud or misinformation so that they can investigate and look into problems that might be happening in your state. And also to inform individuals about their right to complain about wrongdoing if something that happens to them, either when they're being sold a plan or once they're covered by these plans, that they have the ability to complain about that to the state regulator where they live. And then we're also asking today that if you have the bandwidth to send us stories of people you meet that have been impacted by Skimpy plans, because we're also trying to make sure that we're aware of what's happening on the ground. For example, what types of plans people are seeing, what specific kinds of tactics are being used, and what kind of problems that people might be running into, so that we can be aware of that and share that information too. And we'll provide an email address for you to send us emails if at the end of the presentation, if you do pick up, unfortunately, on people who have been impacted. So here's our resource page, and I think maybe I will pause there and we'll take some questions with the time that we have left.
Yeah, thank you, Sarah. So just a reminder to our listeners, if you would like to ask a question, now is the time to do so, and you can do that by clicking the Q&A box on your webinar toolbar. And just a note on these resources, right now, as you're looking at these slides, you can't click these links, but when we distribute the slides after this presentation, we'll put a link on our website and we'll distribute them via a follow-up email. You will be able to access these links to these resources. So let's start here with a couple of questions. This first question, do co-payments count towards your out-of-pocket maximum even if they don't count towards your deductible?
That's a great question. Thank you for that one. Yes, in the marketplace plans, any co-payment, any other kind of cost sharing that is in the plan, a deductible, co-payment, or co-insurance, do have to count towards that maximum out-of-pocket limit. And that's really important because even if the person isn't paying their full deductible first, any dollar that they're paying during the year for an in-network covered benefit is supposed to count toward that out-of-pocket maximum. So that's a really important protection for people that use a lot of medical care in particular.
Another question here, if a client meets the maximum out-of-pocket, if a client meets the maximum out-of-pocket, the insurance company pays 100% moving forward. And are there no co-pays moving forward for the patient?
Right. So if that person meets their maximum out of pocket for their plan, they shouldn't have to pay anything more out of pocket for the rest of the year on anything that they get in network and that's covered by their plan. So I think there would be some examples if, for example, they went out of network or if they got some kind of service that wasn't covered by the plan, then those would be instances where they're not protected by that out of pocket limit. But anything in their plan and that's in network, once they've hit that cap for the year, they shouldn't have to pay any more of their own money.
Do we know the requirements to file as an American Indian Alaska Native to take advantage of the special cost sharing conditions, or is there a resource we can point people to?
I think we could follow up with a resource. I don't know the answer to that myself, but we have some extra resources that we can provide that provides a little bit more explanation about that.
For the maximum out-of-pocket for a family, how is that calculated? Is it based on 2 people, and is it consistent for an entire family, even if a family is greater than 2?
Yes. If there's a family plan and there's a family out-of-pocket cap, that would be over the whole family. So if it was a couple, then that would be their out-of-pocket cap. And if it was a family of 4, it would be across all of them. As I mentioned a couple of times, just because I think it's so important, particularly in a case where there's a family and there's maybe one person in the family who has very high out-of-pocket costs and the other people really don't, they have maybe more average out-of-pocket costs, then that out-of-pocket limit that applies to individuals, the $8,150 that we talked about for 2020, that does apply to each individual in the family. So under no circumstances could that one person have to pay more than $8,150 for the care that they use. So that's sort of a, just an extra level of protection in that kind of scenario. But I think with another important thing to think about with the out-of-pocket maximum is it's very, very unlikely for people to meet that in a year, to hit that in a year. It's really for kind of catastrophically high spending. And typically really it would be somebody that is in the hospital at some point during the year. So it's not most people's experience, but it is a really important protection for anybody that finds themselves in that situation.
And just to clarify, when the out-of-pocket maximum is met, you still have to pay monthly premiums, correct?
That's right. Premiums are separate from cost sharing, and that's really important to know just because people, in order to keep getting their insurance and to keep getting that coverage, and especially once they've hit their out-of-pocket cap, they're going to need to keep paying their premiums to keep the coverage going for the rest of the year. And if somebody's in that situation, they're likely have pretty significant costs, and they wouldn't want to lose their insurance, in September. And lose access to that protection. So definitely have to keep paying premiums the whole way along, even once you've hit your out-of-pocket cap, which is part of your cost sharing charges.
All right, I think that's all the time that we're going to have for questions for this webinar today. Just a couple of notes in closing here. As a reminder, we will be distributing the materials from today's session via an email, and we will post everything to the Beyond the Basics website. That website again is www.healthreformbeyondthebasics.org. The next part of this webinar series covering plan selection strategies is scheduled for this Thursday, October 17th at 2 p.m. Eastern, 11 a.m. Pacific. And you can register for upcoming webinars on the Beyond the Basics website under upcoming webinars. You can also find additional resources on the website, including reference charts, guides, and frequently asked questions. If you have any questions or need any assistance, please email our Beyond the Basics contact email at beyondthebasics@cbpp.org. That email is also the place to send any consumer stories you collect about Skimpy plans. And with that, we will bring today's webinar to a close. Thank you everyone for joining us today.